Can you not share the screen with me or
Uh,
the control with me?
well, now that this is already up, I think we need to just move forward.
Okay. So, um, I don't know how in the world can I go back? I have no idea how I get some topics that there is absolutely no data. It's primarily expert opinion as to what to do. There's a few things that are hardcore that the line is drawn in the sand, but most of it, we don't have good data to support it. So I'm just going to discuss my expert opinion based on what I've read and looked at. Next slide. So delivery for anybody with a preeclampsia with or without severe features should be scheduled at 37 weeks. The same goes for gestational hypertension. And this is one area where there is pretty good data. It was a randomized trial that was basically looked at trying to wait till people got right, until people had gotten a ripe cervix versus just outright inducing them. And it was the maternal outcomes, primarily severe hypertension, was better in the group that actually was induced at 37 weeks. Severe preeclampsia, once you hit 34 weeks, the weight to the risk to the mother outweighs basically any benefit to the fetus. We'll occasionally try to keep a severe preeclamptic pregnant whose baby has a heart defect, but that is the only reason we would ever do this. So delivery at 37 weeks with preeclampsia, gestational hypertension, and 34 weeks with severe features. Next slide, please. So who should be managed as an inpatient? I also think that most maternal fetal medicine doctors would agree with these statements. One, severe preeclampsia, regardless of the gestational age, should be kept in-house. An unreliable patient, a patient with transportation issues, or if you've brought a patient in, you've treated her blood pressure, you let her go home, and she's failed outpatient management, she should come in. Now, I would also consider inpatient management for anyone less than 32 to 34 weeks who has preeclampsia. Now, I once heard Dr. Sabai say there is no mild preeclampsia less than 34 weeks. It's all severe preeclampsia or will become severe in a few days. So I've always kept that in my mind. And if you look at the data about who has the poorest maternal outcomes, it's the people with the early onset disease. And those people tend to get sick quicker, and they have more complications than a term preeclamptic. Next slide. So you can consider outpatient management when you've got a reliable patient, they have good fetal well-being, they've got good growth, and their labs are good. Now, it depends on what source you read as to which labs you should have. I didn't put a PC ratio there because once you get a positive PC ratio, there's really no benefit for repeating it, because proteinuria is in your definition of preeclampsia. And so I personally do the CBC and the CMP. Some people will add LDH, and some people will add uric acid. But uric acid has never been shown to be a part of the criteria for the severity of preeclampsia. And so that is why I don't use it. Next slide. So, again, the outpatient management, you can consider it from 34 to 37 weeks with preeclampsia without severe features, 34 to 37 weeks for gestational hypertension, and less than 34 weeks if they have uncomplicated preeclampsia without severe features. Like your diabetics, your patients with chronic hypertension, lupus, those patients are complicated patients. But if you've got a healthy prima gravida that comes in and her blood pressure is 142/92, and you bring her back in a week, I have no issues as long as her lab's normal and she has no symptoms for you to keep her as an outpatient another week. But you must have, if they're less than, either way, if they're above 34 weeks or less than 34 weeks, you should see them at least once a week. And most people would repeat labs once a week. Next slide. And I just told you what I forgot about this slide. 1 to 2 times a week if they're an outpatient managed, once a week labs, home blood pressure monitoring, excellent educations on signs or symptoms, fetal assessment at least once a week, and always use the right size blood pressure cuff, because a lot of our patients, we don't have the right size blood pressure cuff. Next slide. And if a patient has hypertension on medication already, I don't have any issues increasing medication on an outpatient basis with close follow-up. And if they're not hypertensive, I do consider starting medication. Starting medication won't prolong the pregnancy. It won't improve the outcome for the baby. And we don't have enough data to say it will help the mother, but I want their blood pressure to be less than like 150/100 if I'm going to keep them as an outpatient. I prefer there's like 130/80 and 140/90 as a blood pressure on the outpatient basis. Next slide. So the next question is, are there new tools on the horizon? So back in 2004, I think it was, Anath Karamachi presented circulating angiogenic factors and the risk of preeclampsia at the SMFM, and Richard Levine stood up and said, "We have found the cause of preeclampsia." Well, everybody has always thought whether or not it was prostaglandins or nitric oxide, that they found what causes preeclampsia. Well, S-split is one angiogenic factor, and PLGF, placental growth factor, and VEGF, vascular endothelial growth factors, are angiogenic factors that he looked at. People who have elevated S-splits actually get preeclampsia earlier, and the people who have low PLGF get preeclampsia earlier. So this could be they said when this was presented, we could potentially have treatment on the horizon and test on the horizon. Next slide, please. So in 2016, a group in Europe, this was a multi-centered group, a multi-centered study, that they recruited 500 patients, and they looked at the S-split and PLGF ratio to determine what ratio you could say, well, this group isn't going to get preeclampsia, and if it's this group is going to get preeclampsia. So they took 500 people and they modeled the ratio, trying to pick the break point. And then they took about 500 more people and looked again to see if that break point that they picked worked. And it worked pretty good. Next slide. Next slide. Okay, so they actually picked the cutoff point of 38. And if you looked at it a week before a delivery, it had a negative predictive value of 99% in the development cohort and 99% in the validation cohort. So if you got a PLGF, an S-split PLGF ratio that was less than 38, there was almost no chance that that patient was going to get preeclampsia in the next week. Now, they didn't look at 1 week, 2 weeks, 3 weeks, 4 weeks, and look at the negative predictive value. They looked at out the 1 week and 4 weeks. And the positive predictive value to rule preeclampsia in was really too low to use. And so they recommended to use it as a negative test. Next slide. So there is a group in the United States that was led by Sarah Kilpatrick, and this program was sponsored by Cedars-Sinai and the company that sells the lab. So you have to remember that. But they looked at circulating angiogenic factors to see if they could predict who would have preeclampsia. Next slide, please. So on the left, they actually looked at 2 weeks, and they looked at time in days. So if you look to your left where there's 14 days and the dotted line goes up and down, then the blue line is people who have a PLGF ratio of less than 40. And so 75% of these patients remain pregnant at 2 weeks. But if you were greater than 40, only 33% of those patients remain pregnant at 2 weeks. And on the right side of the slide, it was divided in quartiles, okay? Like if you were in the highest quartile, your number was in the lowest quartile, I should say, less than 40 in that range. If you were in quartile 1, there was an 80% chance that you would be pregnant in 2 weeks. And then if you look at the purple line, if you were greater than 220, there was only a 16% chance that you would be pregnant. Okay, so it's not perfect, but it gives us another tool. Next slide. Now, we've always looked for things to predict preeclampsia, and you can see the blue line. This is the area under the curve. The blue line is the S-flip PLGF ratio, but all the other lines are actually clinical variables, whether or not it's liver enzymes, blood pressure, platelets, creatinine. They all do not perform well predicting preeclampsia. And if you put on there uric acid, it would be just a little bit better than diastolic blood pressure. I mean, it performs pretty good, but the sensitivity is like in the 60s. So you can see that this is the best tool we have yet. Next slide. So the question is, how should we be using this new test? So if you've got a patient who you're worried that might have preeclampsia, you send them to labor and delivery to be ruled out for preeclampsia, and you're still a little uneasy, this would be a good test for them. Or you put them in the hospital for 48 hours for steroids, and you're still worried they got preeclampsia, you could order this test. The patients that are at high risk for progression to preeclampsia within 2 weeks is greater than their ratio is greater than 40. But if it's greater than 220, it really is high risk. And low risk is considered less than 40. Now, again, these tests are not standalone tests. Like, you can't have somebody that's 160 over 110, they got 4+ proteinuria, and this test comes back 38. You cannot depend on that test with alone. And so it's just a clinical adjunct, and it does not exclude our clinical judgment. Next slide. All right, that's the end of it.